Hello everyone, I'm Dr. Xu Hui from the Department of Orthopedic Surgery at Beijing Jishuitan Hospital. Today I'd like to introduce a rotating hinge knee system from AHK Medical, abbreviated as AHK. This rotating hinge system is derived from AHK Medical's A3 knee system, which includes the A3 surface knee, the A3 condylar constrained knee, and the rotating hinge knee. Its greatest advantage is that it does not rely on the knee's collateral ligaments while still restoring excellent knee function. It creates a complete treatment protocol for the knee, from surface replacement through constrained replacement to a hinge-type replacement that does not depend on the collateral ligaments, allowing patients who previously could not be treated or had unsatisfactory results to achieve full recovery. For instance, patients with bone tumors or other conditions can still be successfully reconstructed. So, the entire knee replacement process, from surface replacement to constrained replacement, and finally to hinge replacement independent of the collateral ligaments, is now seamlessly integrated. This is a third-generation rotating hinge knee. It is different from previous heavy-bearing hinge knees. The system comes in various models to accommodate the femoral condyles, ensuring complete load-bearing, improved knee function, restoration of the joint gap, and excellent range of motion. This provides surgeons with more weapons to help patients regain truly normal knee function. Today, I will introduce this knee system in hopes that its features and key operational points will be helpful in your practice. Let's go through the steps. The AHK joint is primarily used for rotating hinge knee arthroplasty. Therefore, most cases involve revision knee procedures or problems related to deficient collateral ligaments. The revision principle is analogous to building with blocks. First address the tibia, then stack up by reconstructing the flexion gap, and finally establish the extension gap. This is the fundamental principle for revisions. Let's begin with the tibia. First, identify the entry point for the intramedullary canal. In revision cases, the most stable structure is the medullary canal, so its identification is essential. How do we determine it? Essentially, if you look at the platform, the tibial tuberosity is seen, and the area opposing it corresponds to the anterior cruciate ligament's insertion. It lies roughly 1/3 from the front and 2/3 from the back. That is where the canal is. Start by opening the canal. After opening the canal, introduce a slender lower limb alignment rod to check that the rod passes through the center of the canal. If it goes down easily without obstruction, then it is centered. This is ideal. Then, in primary cases, or when upgrading from A3, insert the A3 femoral guide rod from this point. This corresponds to the upper part of the A3 tibial ankle clamp. Essentially, it integrates with the initial intramedullary positioning technique. Once inserted, it's quite straightforward. Once inserted and tightened, fine-tune the guide rod until it aligns centrally with the ankle canal. When aligned, gradually lower it. In primary replacement, the lateral side is typically 8 to 9 millimeters, and the medial side is 2 to 3 millimeters. But in revisions, this adjustment is not applicable. Generally, the device is fixed at a level roughly 2 finger breadths above the tibial tuberosity. First fix one pin, then a second, thereby stabilizing the construct. This is one method. Using the A3 method for the tibia provides both intramedullary positioning and an extramedullary check, a very coherent and reliable method. A quick visual check confirms if the axis is properly set. This is one approach. For revisions utilizing the ACCK approach, the technique differs slightly. You attach a long drill bit and drill into the canal. Once drilled, connect an instrument, commonly called the pipe, which is essentially a tibial osteotomy device for cases with bone defects. This pipe has angle markings, ensure it reads 0 degrees, and you then attach it. After mounting it, use a saw guide to check the planned osteotomy plane. Insert the guide. After insertion, use the adjustment bar on top to fine-tune the plane. This is another way to achieve proper intramedullary positioning. In revisions with AHK, the process is integrated. Both methods are valid for achieving intramedullary positioning and establishing a resection platform. So both are correct and effective. The only downside is that extramedullary verification remains necessary. So the guide rod must be thick and long enough to ensure stability, which ensures accuracy. Now let's return to the alternate method briefly described. Move the guide to its lowest point, remove it, reposition it flushes, and recheck. Excellent. Now it's time to saw. At this point, I have created an osteotomy platform. In tibial revisions, you often encounter significant bone defects on the plateau. Therefore, using an intramedullary method, place the intramedullary retractor. Once in place, prepare for tibial reconstruction by positioning the pipe. When you set it, you generally need to choose a relatively high position. What does that mean? It means positioning it at a level where, if you continued, you'd encounter the deficient bone area. The purpose of this relatively high placement is to separate the tibial plateau into two zones, the area above with liner and the area below with metal augment. In other words, you determine the osteotomy plane this way. If the liner is thick enough, use it to compensate. If not thick enough, place the defect below the plateau and use a metal block. This enhances the efficiency of the tibial platform. When using the AHK system, you divide the tibial region into platform above and platform below. The lower platform addresses bone deficiency. The upper platform maintains joint tension. Different components are used accordingly. This is one method to assess bone deficiencies. After creating the platform, first enlarge the medullary canal to accommodate the central portion of the implant. Since the AHK is relatively long, almost no eccentricity is necessary. In terms of length, about 12 centimeters is sufficient. Okay, let's insert the next one. Determine the depth is generally based on the length of the rod you wish to insert. The height of the AHK base plus the rod length is about 5 centimeters, so the overall length is roughly 12 centimeters. Reaching around 12 centimeters usually indicates the proper sizing. At that point, insert the 12 centimeter rod and then place the central locking mechanism. Once secured, you can check that the depth within the canal matches appropriately. If it does, fix the tibial platform. Next, fix the tibial platform. Use the alignment rod to verify that everything is consistent with the prior setup. It should be aligned. Notice how the canal and the platform match perfectly. Very good. Now remove the rod and the intramedullary instrument. Then replace them with a thicker guide, place the sleeve, and stabilize the assembly. Use the thickest instrument to gently rotate it. Once the rotation is set, remove the instrument. Now the rod's length and diameter are set and the platform is established. Only the final component, tibial punching device, is left. Since the sclerotic bone is prone to cracking, gently polish the surface. After polishing, insert the final component, the tibial punching device. After placing, remove all temporary instruments. You will see that the osteotomy plane, the correct axis, and the prosthetic wing components are all in position. Then insert a trial component. Once the trial is in place, the tibial preparation is complete. If needed, you can raise the construct using a metal augment block or a half-side defect block. There are also cones and other metallic substitutes for severe bone defects. These options are available for intraoperative selection. Let's now move on to the femur. The femoral procedure is similar to the tibial one. The femoral canal is the most accurate reference. In primary replacements, the Wasilewski four-quadrant method, or a transverse line, is used to divide the femur. In the anteromedial quadrant, the canal is open 1.5 centimeters anterior to the cruciate ligament origin. In revision cases, the only intact structure is typically the medullary canal. So first identify and open the femoral canal. Then insert the intramedullary rod to the distal femur. This is the A3 primary replacement technique. In primary cases, the intercondylar notch is typically used. This constitutes the distal femoral osteotomy. Typically, measurements are taken using these landmarks in primary replacements. However, in revision cases, these reference surfaces may no longer be present. In such cases, I create a tibial platform. This is a surface I developed. Therefore, in CCK procedures, you need to set the rotation carefully, ensuring close contact with the tibia. Gently lift it to observe its external rotation in relation to the soft tissue. This helps determine the correct position. This observation helps guide your measurements. You can then estimate roughly what implant size will be needed. Alternatively, use the curved sleeve from the AHK system to measure the anteroposterior diameter. For example, if it's about 3 centimeters, this gives you a clear and intuitive sense of the required size. This is one method. Also consider the transverse diameter. Use a trial component to compare the transverse width. Doing so may suggest that a size 3 component will be appropriate. So with both measurements, the AP and the transverse, you can determine the prosthesis size. This allows you to estimate and finalize the prosthesis size, then determine the rod position. For example, once you've roughly selected a number, 4, adjust the rotation by gently lifting to verify its alignment, and then fix the rotational guide pin. After placing the rotational guide pin, attach the 4-in-1 cutting block. For the AHK, a number. 3 corresponds to an A3 number 4. Once the pins are placed, lift the component to verify that the tibial resection line is parallel to the tibial platform, which confirms that the external rotation is appropriate. If the direction is parallel, this confirms that the external rotation is correct. Even without the collateral ligaments, the overall alignment should appear balanced. This is especially critical in primary replacements. Next, proceed with the osteotomy. The 4-in-1 cutting block. If it's a revision, this step may be skipped. The key point is to check that the balance is correct. You need to determine the external rotation of the prosthesis. Since the collateral ligaments are still intact, if they are not satisfactory, you will need to adjust the rotation through soft tissue. Once that is done, move on to the intercondylar part by first securing the intramedullary rod. Next, position the intramedullary rod and then place a sleeve. Because the external rotation has already been determined, position the support bracket accordingly. Place the component and first, check with the centering piece to see if both sides match. If they match, this confirms that the centering piece can be removed. If not, use an eccentric component to adjust. Adjust the alignment so that the osteotomy plane and the coverage are optimal. Then note the scale reading. Record this value because it will be referenced later when using the eccentric rod. After recording the scale, the rod will be positioned here and secured at that location. I place it here. After confirming whether the system is eccentric or not, install the final component that fixes the rod using a determined diameter, in this case size 18. Remove the adjustment tool. The 2 pins placed earlier remain as references for positioning the intercondylar component. Begin by determining left versus right. For the left side, place the left rod upward or toward the sky, medially. First, attach the device called the intercondylar osteotomy guide. I place it on the left side. Since external rotation is already set, only the left component is needed. Check if it is eccentrically positioned as determined, then fix it. This essentially sets the prosthesis position, rotation, and intercondylar alignment. Next, drill to secure the intercondylar cutting block. Once the intercondylar block is secured, remove the central impactor. Then remove the guide pins so that the intercondylar preparation is complete. Then remove the guide pins so that the intercondylar preparation is complete. For the femur, if it is a revision case with bone loss, measure the anterior-posterior AP dimension. If a number 3 fits best in AP and the transverse measurement via the trial indicates a number 4, you can choose either. But generally, you use the transverse dimension as the reference and select a number. 4. Then adjust according to the flexion and extension gaps. In revision cases, if a number 4 produces an overly tight flexion gap, then you must switch to a number 3. If a number 4 is used but results in a loose flexion gap that requires a larger posterior augment to balance, then that augment's capacity to achieve balance will decide the final choice. In essence, the flexion gap determines the extension gap. After testing, if you find that a 12 mm liner maintains a stable flexion gap with the femoral condyles in place, then 12 mm is sufficient. Similarly, if both flexion and extension gaps are intended to be 12 mm, but, for example, the extension gap is too loose with a 12 mm insert, then the femoral component may need to be shifted distally to balance both gaps. Conversely, if using a 12 mm liner yields an excessively tight extension gap, extra distal bone resection is necessary to enlarge the extension gap so that both flexion and extension become balanced. Hence, the building block approach is to first establish the tibial platform, then balance the flexion gap, and finally balance the extension gap, a very important principle in revision knee surgery. If after trying, you find the flexion gap is too tight to fit the implant, use a number 3 liner to maintain the flexion gap balance first, then assess the femoral extension gap balance. Hence, the building block approach is to first establish the tibial platform, then balance the flexion gap, and finally balance the extension gap. This is a very important principle in revision knee surgery. Once the trial components are in place and fixed, and after the rotating component is inserted, you may notice that bony coverage over the implant is not completely uniform. By fine-tuning the position, you achieve optimal bony coverage on both sides. At this point, note the distance between a reference line and a marker point, often referred to as 3 offset 1, meaning 3 to 1 offset. Record this value so that later you can position the eccentric rod at that exact location. Then, using the rod, verify that the left side is correct so that bony coverage is ideal. Mark that position and then fix the intercondylar component. This is the use of the eccentric rod, and the same principle applies when using the trial implant. You still see that same reference line. 3. This is the 3 to 1 offset with one small grid. Place it here. Once placed, continue to adjust it down. For the femur, and similarly for the tibia, if you choose a certain size for the tibial component, say size number 4, then in principle the femoral component should also be chosen as number 4. Ideally, you select a tibial component that is slightly larger and a femoral component that is a bit smaller to achieve better compatibility. In other words, if the femoral implant is too large relative to the tibial platform, then a very bulky polyethylene insert might cause the tibial platform's metallic edge to impinge during rotation, leading to pain. Thus, the general principle is to use a smaller femoral component with a relatively larger tibial platform for an optimal fit. Next, implant the femoral component. After placing it, use the saw guide or sickle to check whether there is any bony deficiency. For example, if you notice about 0.5 centimeters of bone loss on the distal side, then perform additional resection with a saw to create space for a 0.5 centimeter augment. Trim accordingly to accept the augment. Also check that the smallest available AHK liner will fit. If one side is too tight to accept it, then adjustments must be made. The final decision on liner size is determined by the flexion gap. Additionally, evaluate the height by checking the tension of the patellar tendon. If it is appropriately taut, then the height is acceptable. If it is too tight or too loose on either side, it is not optimal. Once everything appears balanced, proceed to release, cut the collateral ligaments. Without cutting them, it is extremely difficult to reposition the prosthesis and insert the liner because the soft tissues are too tight. So, at this point, sever the collateral ligaments. After releasing the collateral ligaments, install the liner. Once the liner is placed, lock the two components together. Secure the liner, insert the central pin into the medullary canal, and tighten the screws so that everything locks into one unit. This completes the locking of the AHK. You will then see that, even without relying on the collateral ligaments, the knee remains stable. In this system, stability that would otherwise depend on the collateral ligaments now relies on the patellar tendon. The proper function of the patellar tendon is the key factor in determining the liner's size and thickness. Moreover, you will notice that even when the knee is in full extension, there is no lateral play because the system is locked and the knee is well stabilized. Also, note that the load is distributed over the entire condyle rather than just the axis. This is a key feature of the third generation AHK. The entire condyle bears the load and maintains medial lateral stability without reliance on the collateral ligaments. These distinct characteristics offer significant advantages in knee arthroplasty. It greatly assists the surgeon in restoring both normal knee anatomy and function. Its design is markedly different from previous systems, and in appearance it is very similar to a surface replacement. Thus, this system is a continuation of the A3 series, a comprehensive knee solution. It allows even patients with severe bone defects or irreparable collateral ligaments to receive a rotating hinge knee and regain proper knee function. Now I will describe the assembly of the AHK prosthesis. First, open the AHK kit, which includes the femoral component, tibial component, extension rods of different lengths and eccentricities, a central locking axis, and the liner. Assemble the components together. First, assemble the femoral side. With the femoral side installed, move on to the tibial side. Generally, because the tibia is robust and long, it is rare to use an eccentric rod here. I favor a straight rod instead. This is because the eccentric rod has less capacity in the femoral diaphysis. If the superior coverage on the tibia is poor with an eccentric rod, you might need to downsize the tibial platform to achieve adequate coverage. Thus, in deep resections, it is less common to use an eccentric rod. Also note that there is a special narrowed section designed specifically for Chinese patients. For very small bones, if this cortical preserving feature is not used, too much cortex may be removed, which can lead to splitting. Once assembled, insert a screw from this area and tighten it with a screwdriver. Here is a screw, inserted from here, and once inserted, use a screwdriver to tighten it. Place the tibial liner as needed. After placing the tibia, the femur is then placed. Then insert the screws, push them down, and use a large torque screwdriver to lock them in place. After the assembly is tightened, under load, the construct fully bears weight without medial lateral motion and remains very stable in flexion. This is a hallmark of the third-generation hinged knee. It completely encompasses the joint gap between tibia and femur. With the liner, the joint gap height can be adjusted to ensure proper patellar tendon tension and knee stability, all without relying on the collateral ligaments, because the prosthetic hinge stabilizes the knee and restores function. This completes the implant assembly. Now let's implant the components. First insert and fix the tibial component, then insert and fix the femoral component. Next, place the tibial liner, align it, and insert the central pin. Then insert the pin fully, and using a torque wrench, tighten it. Once tightened, realign the components, raise the leg, and you will observe that the knee fully extends. At this point, check the range of motion. Even without collateral ligaments, the knee remains extremely stable, and with only a slight offset to avoid overextension, the tibial platform fully bears weight. This is the distinguishing feature of the third-generation AHK rotating hinge knee. It does not rely on the collateral ligaments, allows full extension, and maintains reliable load bearing. This marks a significant improvement over previous designs. Today we introduce the surgical technique and design features of the AK Medical AHK rotating hinge knee. This is a new third-generation rotating hinge knee which functions independently of the collateral ligaments and is part of a comprehensive knee treatment system. It does not rely on the collateral ligaments, and this knee prosthesis contributes to a complete solution for knee joint problems, offering clinicians new tools for addressing knee issues, allowing many complex problems to be addressed with prosthetic solutions, providing both prosthetic support and technical options, giving us more choices, and offering new pathways for patient recovery.